Hello everyone and welcome to our YouTube channel if you are watching us on YouTube. Here we have Professor Balasubramanian, who is an associate professor of industrial engineering at UMass Amherst. And as UMass Amherst Informed Student Chapter, we had the pleasure of inviting him for a great talk last week here at Eisenberg School of Management. And now, as the members of UMass Amherst Informed Student Chapter, we would like to interview him, and he gladly accepted our invite, which we are very appreciating. And I would like to give a brief summary of his career before we move on to the main points from the talk and then our questions. Dr. Haris Balasubramanian utilizes research methods in optimization and simulation, stochastic modeling, and statistical learning to improve healthcare delivery. And his research has been funded by multiple grants from the National Science Foundation, including an NSF CAREER award as well. Dr. Hari, welcome to our interview, and thank you so much for giving a great presentation. I'm sure everyone in the audience enjoyed and learned a lot, and so did I. I would like to first ask you if you would be able to summarize and give main points from this talk for our audience who is watching the video right now before we move on.
Yes, thank you, Bushra. I appreciate the introduction, and I really enjoyed giving this presentation as well. So for the audience out there, I want to summarize the talk. This is a very specific sort of domain. It has to do with how do you improve the health and well-being of patients who have a complex set of medical conditions as well as social needs. Such patients typically represent only 1 to 5% of the population. They have very, very high costs. They have a disproportionate impact on the health system with regard to costs and how much they use emergency rooms and hospital care. They also have they have very high costs, but these costs do not necessarily decrease over time, and they keep persisting. And so many organizations around the country have been trying to find out ways in which to help these patients so as to reduce healthcare costs, and most importantly, improve the health and well-being so that the patients do not need to use emergency rooms and hospital visits unnecessarily. There's often social issues tied with this, issues such as not having housing, substance use disorders, not having caregivers to help them. And as a result, this becomes both a medical as well as a social problem. So what many organizations have done is they use community health workers, social workers, and nurses to assist such patients. And there are dozens of such programs ongoing across the country to help this vulnerable group of patients. And this talk was specifically with a group in Camden, New Jersey. And they have been helping patients with complex medical and social needs for the last 21 years now. And the special thing about this group is that they have been very good at collecting data, and they have done a randomized control trial and evaluation of whether what they do to help these patients actually works or not. And so that's what the talk was about. We considered multiple aspects of the talk, such as staffing, the impact on patient outcomes, and some of the challenges. So I hope that summarizes the main content of the talk.
Yeah, thank you so much for a comprehensive summary of your talk, that we all learned a lot and we want to learn more. So I would like to ask more questions to you. So let's start with the randomized control trials that you've mentioned in your talk. So my question is, how do you distinguish between patients who benefited from the system and those who didn't? And were there any caveats that you would like to mention?
This is a great question. It's a very important question. It's a question that groups all over the country that are trying this type of intervention are also asking. So the randomized control trial started in 2014. It basically randomly assigned patients into two groups: people who receive help from a care team, individuals with complex medical and social needs who receive help from a care team, and another group that has usual care. So they might go and do the usual things. They don't receive any special assistance from the care team. So about 400 individuals were there in each group. And the types of interventions they received were very different. And so the amount of time spent by the care team with the patients was also very different. So this trial was very different from, let's say, a trial for a vaccine where everybody receives a placebo or a vaccine, because everybody receives a different kind of dosage of the care team, the amount of time they spend with the care team. So the success is, how do we know that, how successful it was for some individuals or not, is one of the hardest questions of these randomized controlled trial, to measure in this randomized controlled trial. And the overall results showed that actually in terms of hospitalizations and costs, the two groups were actually not very different. And so the question was, did it not have an effect, or is it that maybe the people in the two groups were very, very different from each other in their needs? So new studies are showing now that some individuals who engaged with the care team more, and this is based on some new methodologies and what is called a secondary analysis of the randomized controlled trial. They're finding that some of these individuals actually who engaged more with the care team, they were repeatedly present when the care team was trying to help them. They wanted the help. Such individuals benefited more, and there is a significant difference amongst those individuals in comparison to the control group. Similar individuals in the control group, these individuals who did receive and did engage had lower hospital use and emergency department use as which was actually one of the outcomes that was of interest. So there is you can say that there's a wide amount of variation in how the intervention was and how the impact of the intervention was as well. And we're trying to piece together some other aspects by studying subgroups of individuals who might have benefited more from it. So this is actually one of the methodological as well as practical challenges. Is how do we quantify who did better and who did not? We also don't have patient-reported measures, like how did they feel as they received the help. This was not tracked during this control trial. It is probably one of the most important aspects that should have probably been tracked in both groups, but for a variety of reasons, it's hard to track sometimes. And so we don't have patient-reported outcomes, which is I think, one of the bigger missing pieces in this trial.
So I would like to move on to a question about excess healthcare costs, which is, of course, one of the main aspects of your research. So unexpected medical visits are one primary driver of these excess healthcare costs, and the implemented strategy reduces excess visits and costs through better detection and prevention and improves patients' compliance and outcomes. So my first question is, what is the primary barrier to broadly implement this type of intervention, and how could it be streamlined? Like having enough trained staff, regulations, conflicting institutional interests, which require custom implementation, and so on.
Right.
Yeah.
So this is a very good question. It's very difficult. So there are several sort of aspects to it, and the most difficult aspect to what we call these complex care interventions for these patients is that it requires not just the medical community or the hospitals or the care providers in a city or town or region to come together to help these patients. So first of all, it requires agreement within several players in the healthcare system, like the area hospitals, primary care physicians, specialty care providers, and so on. But it also requires what is called the whole city or region organizations and agencies in the whole city or region to sort of come together. And that's what was achieved in Camden, and which I didn't go into it as much during the talk, but since 2002, they have been bringing together multiple stakeholders from the city, like churches, community service organizations, social service organizations, housing organizations. They all have been coming under what is called this broader ecosystem. So they recognize that it's not just about health. It may be about housing. It may be about substance use. It may be about mental health. So how do you bring in a whole group of providers from different sectors to work together so that the safety net or the help that is available for individuals in a whole city or region is improved? So there's in sort of the operations research terminology, there is a significant setup cost to starting these programs. And it takes maybe years to create an environment where such a thing happens. Once that is set up, then how do you identify patients in the community? Is it going to be in the hospital setting? Do you have lists of patients who might need help, whom care teams can approach? In the Camden case, they approached patients when patients were hospitalized, they were in the hospital. So all those decisions have to be made and I think different organizations do it slightly differently. And so I don't think that there is actually a single approach that will work for all communities, because the problems are also different, let's say, in California versus the Northeast. But there is a general sense that you cannot just bring together medical providers to solve this problem. You need the social service agencies, the mental behavioral health agencies, the substance rehabilitation programs for substance abuse also have to come together. And maybe there are other groups and other charity organizations that need to also help with this. So
the whole community.
Yes, exactly. And that could be the most intangible of the benefits of this, rather than the trials themselves. It's like, the community discovers the problems that are in it.
Thank you so much for that answer, but I would also like to move on to this second part of this question. When you think of mitigating the small groups' extreme costs and health needs, where do you think the most likely breakthrough will come from? Especially since you were talking about different stakeholders, different locations. So do you have any estimations? Do you have any guesses?
Right. So this is probably the bigger question that sort of is lingering over this area, is exactly what is a good, where are the biggest breakthroughs going to come from? So one is that if every city, community, region, state, country were to become aware of who this group of patients is, and through data, through awareness, through TV programs, or through community events, first of all, there has to be a greater awareness. And then based on that awareness, there has to be, I think, goals within a region, city, or wherever these programs are being implemented, of what are the things that are needed by the people who have these complex medical and social needs. So this might be, is it housing that is the biggest concern? So I think it's about strengthening the resources in each community, knowing where it's lacking, having an awareness of it, and avoiding anybody being in the situation in the first place. So I think hopefully it shifts from reacting to the problem, where the problem current now is people have these issues, they need the help, to strengthening the resources in the community so that those sorts of situations actually never arise in the first place. So I'd say that it's that the biggest thing would be a long-term fix. It might not be a short-term one. Although in the short term, this kind of help, strengthening community health workers, for example, community health worker programs to work with these patients, that would be greatly beneficial. I think it's being used increasingly across the world, actually, not just in the US. So social worker programs could also increase, and that could also make a big difference.
Yeah. And you were mentioning raising awareness about this. And even this interview is basically telling people more about this project who might have never heard of the Camden. So once again, I would like to thank you for this opportunity. So my next question is, it seems like complex care is heavily dependent on access to trained staff, and you were just mentioning actually social workers and community workers. So what happens if some years the amount of staff is at a record low or high, and do the models take all these things into account? And if so, how is the robustness of this model?
Yes. This is a great question. Actually, we grappled with this a lot in our models as well. So what happened is, so the example of Camden itself, the Camden Coalition itself is very interesting. Is that they started off very small. They started off with one team, maybe 5 or 10 patients. They started in 2007. And then as their program became better known through better media articles that cited what they're doing, they started to increase their staffing. And then the enrollments also went up. As patients in the community heard of this program, the enrollments also went up. And so they actually never had something like a static model. It was always changing. The staffing levels changed. How the staff, the protocols, and the workflows by staff, they realized that they could improve on from their prior experience also changed. So we've used data from 2012 all the way to 2019 to sort of see if we're seeing some significant changes and how the staffing levels were. The models that we have right now assume that the workflow is steady, but I think what we could do is, if there are periods of highs or periods of lows, then you could change the capacity availability for these staff members in these models. You could play out several scenarios to say, okay, well, or you could have high patient enrollment times when the patient enrollment rates are expected to be high, and certain areas where it sort of goes down. And then you could play out to see, do you need to scale back or increase the staff? So we have created a simulation model that is that has these broad features that you can play with. And we did consider in the paper, although I did not have time to discuss it in the presentation, we have a case where the enrollment rates increase, and how does staffing have to catch up to these increased enrollment rates? It's very difficult to predict when enrollment rates will increase, but at least if they do, then care teams can use these types of results to plan their staffing. So, yes, so that would be, and then we don't have models based on capacity limits yet, but that's a very easy extension, and one of my students is working on. So capacity changes over time, and we could see the effect of that.
Yeah, maybe we should also remind our audience that this is a huge project. You are working with many students, graduate students. Yeah. So
it's a 3-year National Science Foundation grant, which just started last year, and then we have 2 students now who are working, 2 graduate students, PhD students who are working on this. Yeah. So we'll hope to have more results on this in a couple of years.
Yeah, hopefully. So one thing that you said resonated with me, which was the problems in New Jersey area will not be the same as California, for instance. So let's build a little bit more on that. How can your models for answering questions related to staffing and operations be generalized? Like, what would be difficult to adapt from the New Jersey area where they are tested to just like you said, California? What are some of the assumptions and limitations? Maybe you could give us more of an idea.
So I do think that specific, for example, whether the problems occur in a rural area versus urban area. So in a rural area, you have patients who are in a very wide range of communities that are very far apart from each other. So we've had programs, or at least I've heard of programs, where a registered nurse would have to drive out to so many different locations to sort of see their individuals, the patients they're caring for at their homes, and help them out. So it almost becomes like you've got sort of these appointments, but you've got the travel schedule to sort of align with it. So that becomes a challenge of its own. And then, you've got maybe some areas which have one feature more than other. Maybe substance abuse is very significant in some communities, where maybe there may be high unemployment, no prospects of jobs are low. You have a certain type of social needs that are higher. And in crowded cities, you have other types of situations. Maybe housing could be a bigger problem, for example. So you've got you've got sort of this mix of things that are very different, and so the programs also have to be adapted to that. So the types of staff, maybe you need more social workers in one, maybe you need more registered nurses in other if the problems are more clinical. So I think we're finding that the more I read about these programs, that they actually are quite different, although the overall template or the features are very similar. They too do tend to differ. So what the Camden Coalition, the organization I'm working with, they have done is they have started a National Center for Complex Care. And they bring this national center brings together organizations from all over the country for a national conference, and that national conference is going to be held November 1 to 3 in Boston. It's called Putting Care at the Center, and this is my first time I will be attending that conference as well. And what they're doing is trying to share what they have learned, and also allowing other organizations to share their specific models of care or findings at this conference. So what the Camden Coalition is doing is also sharing their knowledge and creating this forum. And I think through this, some of these differences and like what should be done in California or the Pacific Northwest versus the Midwest and rural versus urban will start to become more and more clear.
Yeah. To clarify, that conference in Boston is not held the first time this year, right? It has been going on.
It has been going on, yes,
yeah.
Right. So it's a center that started in 2016, and
okay.
I think maybe even from maybe that year or 2017, they have been holding a national conference. And last year it was held in Los Angeles.
Oh.
And it's also sponsored by different organizations. So this year in the Boston one, one of the sponsors was the Commonwealth Care Alliance, which is doing similar work in the Boston area or in Massachusetts. So. And so it's kind of a way of people who are working in this field to come together. Yes.
Yeah. Well, that sounds amazing. I hope you have a great time at the conference, and it brings you a lot of insights for your research too. So let's move on to our next question, which is, you answered this a little bit, but I would like to just learn a bit more. What are the main challenges of working in teams with multidisciplinary experts in the healthcare industry? And how would an efficient collaboration result in a effective intervention for people in this program?
Right. So this is actually one of the harder questions for researchers who are interested in healthcare, researchers in operations management or operations research. They want to do some work in this area, but they struggle to find collaborators. And I think the reason is this takes a long time. So usually, for example, in my case, I'm presenting this in 2023. I visited the Camden Coalition's open house in December 2014. And that was my first sort of encounter with them. And within 3 months, they had agreed to work and they had shared the relevant data. But that doesn't happen often with many organizations. First of all, they may not have the data. And then you have to clear several protocols to be able to share the data. So if you're interested in data-driven research, there are actually several challenges, and you need somebody who's what you might call who's an advocate for you on the side of the organization you're working with. It could be a physician, it could be a nurse, it could be a pharmacist, it could be a data analytics person who works in the healthcare domain. So finding that person requires multiple attempts. Okay. And often I start 5-6 projects, of which maybe 1 or 2 actually lead to longer term successful projects.
If you don't mind me asking, who was the advocate in your case?
Yes, so it was, that person is now the Director of Strategy and Analytics in the Camden Coalition. His name is Aaron Truchell, and he's a co-author in several of the papers. And he's not a healthcare, he's not a physician or a nurse, but he had a sufficient, he has been at the Camden Coalition since its very early stages, knows the data and the program extremely well, and was especially useful with allowing the data to be analyzed. And so usually I'm working with the hospital right now. We have been working for the last 8 months to get data. We still don't have data. So that's how hard it is. And so they were able to send it within 3 months. So I think that was, so in this case, it was Aaron Truchell who helped with this. And in other situations, it has been, there's a nurse at Bay State Medical Center who was a very strong advocate of the project we were doing with her on discharge planning in hospitals. So that worked very well. From 2011 to 2015, we worked with Bay State Medical Center. We would go there every week, and they would again give us the relevant data. So you need this advocate, and somehow finding that advocate requires multiple trials and also being present at meetings, which may not lead to anything in most cases, but in some lead to some successful collaborations.
Yeah. I mean, that sounds very complex, and I'm just glad that so many people are involved to have positive outcomes for people involved. So this is the last research-related question, and it is a little bit different from the previous ones because it is about your paper titled Dynamic Allocation of Same-Day Requests in Multi-Physician Primary Care Practices in the Presence of Pre-Scheduled Appointments. So, and in that paper, you propose an easily implementable policy for scheduling both pre-scheduled and same-day appointments. Can you tell us briefly about this policy and why its ease of implementation is so important?
Yes, so this paper was published, I believe, in 2014 in the journal Healthcare Management Science, and it deals with an access problem in primary care. So essentially, when you call primary care physicians, you want an appointment today because you have something that's not an emergency, but would like to be seen the same day at least. You don't have to be seen immediately, but maybe within 3, 4, 5, 6, up to 8 hours. So when you call, often the calendar of physicians is already booked with patients who have scheduled their appointments long ago. And those need to be respected as well. And so if the physician's calendar is completely booked in the afternoon, somebody calling in the morning would not get an appointment in the afternoon. So a person who needs an appointment today on the same day calls, let's say, at 9 a.m. in the morning. They want to see their own physician, whom they've seen many times in the past, who understands their history and their medical conditions. So they call at 9 o'clock. The physician's calendar is booked for all afternoon by people who needed regular checkups, pre-scheduled checkups. And so the afternoon calendar is fully booked. And so there's no way for this person who needs same day to get in, except at the expense of overtime for the physician, but too much overtime can cause burnout for the physician as well. So this is the trade-off that we were dealing with, and the specific policy that we tried to sort of model there is, what if we moved pre-scheduled appointments more towards the morning? If you're able to do that, then people who call in the morning for same-day appointments can still be fit in the afternoon. And this is a dynamic process. People call in at 9, people call in at 10, 11, 12. So if you have some space towards the end of the day, then you're more likely to squeeze them in. But if you schedule pre-scheduled appointments all in the afternoon, then the afternoon is blocked. For the morning people, there's very few slots available. And so we said, okay, well, let's try to move pre-scheduled appointments in the morning. But sometimes that can be unrealistic because the pre-scheduled patients also have preferences for slots. Yeah. So we use something called a 2 blocks policy, which is like a little bit in the morning, a little bit early afternoon. So there's sufficient gaps in the morning as well as afternoon. And that worked almost as well as shifting everything, all the pre-scheduling into the morning, which is sort of the benchmark or best case. So it's a little flexibility in changes in schedule, but still it produced good results, this 2 blocks policy. A little bit in the morning, a little bit early afternoon. That still gives enough ability for same-day patients to receive care during the day. So that was what we tested in that paper.
And I can see how implementable it can be for many healthcare centers. So this was the last research-related question, Professor Hari. Thank you so much for answering all of our questions and informing us more about this really valuable research project.